So our next presentation will be given by Prof. James Howard. Prof. James is a professor of neurology, medicine, and allied health at the University of North Carolina. Chapel Hill School of Medicine and has been participating neurologist for over 30 years with the clinical focus on patients with myasthenia gravis. Dr. Howard is a leading expert in myasthenia and is well published in the field. He's one of the 7 members of the recently established Funded of Rare Disease Clinical Research Network for myasthenia gravis to further advanced myasthenia therapeutical development and disease research. So welcome Prof. James.
The focus and talk to some of the emerging therapies to treat myasthenia gravis. How we treat MG today will not be in existence, I predict, in the next 5+ years. And you're going to see a radical shift in our ability to treat the disorder as we develop new targeted therapies that have much better side effect profiles. And I want to share with you where this field is going. These are my requisite disclosures. I consult for a number of the pharmaceutical companies who are developing new therapeutic strategies. Most, if not all, of the drugs we talk about today are not available or not labeled for myasthenia in the United States. They're either experimental or we use them off-label, other than one, and that's eculizumab. This program is coming to you, and I've been asked to show this slide from Biologics and their involvement with Alexion and eculizumab or Soliris, which is available for folks in the UAE. So as I said, most of the complement inhibitors, FcRn inhibitors, are all investigational drugs. In the US and many places in the world, eculizumab is the only approved complement inhibitor to treat myasthenia. In fact, the only drug approved to treat myasthenia, and everything else we use here in the States anyway is off-label. So myasthenia has changed drastically over the last century. And in the early 1900s, there was a mortality that approached 100%, primarily due to infection and respiratory failure. In the advent of antibiotics in the mid-1930s and the role of ventilation at late 20s and early 30s drastically improved the mortality rates of myasthenia. As you can see, let me get my pointer here, down to less than 50%. And we've had some further improvement as we improved ventilatory support. And it wasn't until the mid-60s that we had any form of immune suppression, initially with ACTH and subsequently with corticosteroids, with which we saw further improvement in our ability to treat the disease and diminish mortality. And then we've had a sequence of immune suppressive drugs, the azathioprins, cyclophosphamide, the cyclophilins with tacrolimus and cyclosporin, mycophenolate, methotrexate, etc., as well as plasma exchange and IVIG that improves slightly the asymptotic curve. And this is all great, but despite that, patients have a continued deficit, if you will, an unmet need that in some estimations approaches 30%. And why is this? And I hope I can give you a flavor for that. This is data taken from the Myasthenia Gravis Foundation of America patient registry, has well over 2,000 patients self-reported, and with that, of course, are inherent biases. But when we look at one of the metrics, a myasthenia gravis activities of daily living score, anything over 6 is moderate impact in terms of symptoms or disability. And more than 50% of patients who were reporting into this registry reported ADL scores that were 6 or higher, suggesting that despite all, they had unmet needs. And when we look at their quality of life instruments, and this has also been duplicated in the Netherlands, I think there's another study that comes out of Japan where worsening score is higher numbers. Well over 50% of these folks have QOL scores in excess of 20s. And this represents significant impact on their ability to function socially, in terms of their job, in terms of their own personal living interactions, etc. And so this is one aspect of, while we have improved the physical components in large part of many myasthenic patients, there are still domains that are not acceptable to the patient, if you will. And then one of the things that we have neglected for decades is what's the effects of our treatments that we use. And many of you are well aware of the role of cholinesterase inhibitors, corticosteroids, and other non-steroidal immune suppressive drugs such as methotrexate, the cyclophilins, mycophenolate, etc. And many of you use some or all of these in your practice based on what's available by your health ministries. Patients don't like these drugs, and they don't like them because of the adverse events, which can either be acute or can be very chronic with long-standing use. And I've listed some of these here. The worst offender, of course, is corticosteroids, and patients just detest this drug in my experience. It alters mood, it alters body physiognomy, so they develop Cushingoid features, they get hair growth, they get fat, which is an anathema to them. To say nothing of the effect that the long-term risk of weight gain, which often is not completely reversible, the development or the worsening of glucose intolerance and bone health. And then we look at all of these other immune suppressive drugs, and we're looking at GI intolerant, mycophenolate. The worst offender is the chronic diarrhea that they develop, and I have patients who have 15 to 20 stools a day, to say nothing of bone marrow suppression, renal toxicity, etc., malignancy, and then the effects in the childbearing potential. And clearly mycophenolate is the worst, with a very high incidence of first trimester spontaneous abortions because of the toxicity of the drug. But why do they take it? They take it because they are physically stronger. And until we had newer therapies, they put up with this, though hating it. IVIG and plasma exchange are not without risk. And over my 40 years, although IVIG did not come about until the mid-80s in my practice, I've infarcted every organ system, the bowel, the eye, the gut, the brain, the heart, kidney. And so in certain populations of patients, these two are not without risk. The same with plasma exchange. And so we have issues there. Rituximab has gained favor in the armamentarium of our treatment protocol. Fantastic drug to treat musk myasthenia. It's my personal belief it's not so great in AChR positive myasthenia, and the largest study to date failed, and that may be due to other reasons other than drug effect. It could be a design failure of the study, because there are studies out of Europe, though small on scale, that say it can be effective. But 15–20% have anaphylaxis when it's first used, and they have to be desensitized. In some individuals, and from a rheumatologic population, 10% of their patients lose their B cells forever. They do not recover. And then there's rare instances of PML, progressive multifocal leukoencephalopathy. Eculizumab, the first targeted therapy that we have to a single target, that's perhaps the primary pathogenic mechanism. We have the role of meningococcal infections. While small, it's not zero, and they have to be immunized appropriately, and they have to be counseled for the signs of meningococcal disease so that they can seek medical attention rapidly. So while we have lots of drugs and many of them do well from a physical perspective, they clearly have issues when it comes to the overall well-being of patients, which now with newer therapies, we have to start thinking about in terms of what are the AE, adverse event profiles of what the drugs that we use. When we surveyed patients, and this is not my data, but again, taken from this Myasthenia Gravis Foundation registry, what's the problem with your treatment? And depending upon the drug used, 80% talk about side effect issues. A third of them say it's difficult or it's inconvenient. A smaller number talk about the lack of efficacy. But the real problem also, in addition to side effects, is how long does it take before I see an effect of my therapy? Steroids work very quickly, in a matter of weeks. But when we look at azathioprine, which is the other outlier, it may take 10 months before we start to see meaningful therapy, 3 years before we see the full effects of the drug. Many of the others take 4 to 6 months before we start to see improvement, and more than a year before we see full efficacy. And if we're cycling patients because they're not responding to drugs, just think about the timeline it takes before we can try drug 2, drug 3, if you're giving them a fair clinical trial of the drug. And it often expands over several years where they still struggle with their disease and do not have quality of life issues. I'm going to try to convince you that current therapies under development are going to change many of these dissatisfactions, if you will, with much more rapid time to onset of effect, targeted therapy with much less side effect, and with improved efficacy. And I want to share with you this information. Some of you have heard parts of this talk, particularly as it applies to complement inhibition, and I apologize for others of you, this will be new. We know that complement activation is the most important mechanism for the pathology in AChR positive myasthenia. This is now readily apparent, but it took us almost 3 decades to get here. Andrew Engel at the Mayo Clinic first demonstrated the role of complement at the neuromuscular junction, but we could do little with it other than some basic science to continue to prove that. We now have tools. And what's happening is that as antibody binds to the receptor complex, it activates C1QRS of the complement cascade. And I'm not going to go in and talk about the complement cascade. We don't have time with this very short presentation, but the effect is that we activate or develop what's called the membrane attack complex. Now, in some circles, it's called the terminal complement complex, which is a ring-like pore structure that literally drills holes in the muscle fiber membrane and destroys it. We leak internal contents and it becomes dysfunctional. And it's this membrane attack complex that describes the architectural destruction that occurs at the neuromuscular junction. This is Andy Engel's work, and here's a normal neuromuscular junction. We have excellent post-junctional folds. The receptors live on the tops of these folds. And this architecture is because with this design, we can have high density of receptors rather than a flat surface membrane. And here's complement activation. Here's the membrane attack complex, which is composed of various components of 5B, C6, 7, 8, and 9 that drill these holes and literally destroy the neuromuscular junction and results in synaptic failure. Back in 2007, we began talking about the role of complement as a therapeutic modality. It had been under trial for paroxysmal nocturnal hemoglobinuria, and initial trials were starting for atypical hemolytic uremic syndrome, 2 other complement-mediated disorders. And we had discussions with a company, Alexion, as to whether this would be efficacious in treating myasthenia gravis. A phase 2 trial demonstrated efficacy, and as a result, a phase 3 trial was done, which ran through sort of the end of around 2015-ish, 2016, and subsequently has been approved in many countries throughout the world for treatment of MG. We're not going to go into all the data in depth, only to show you that red is placebo, blue is active drug, and this is administered following a loading phase and appropriate immunization against meningococcus, and then administered every 2 weeks intravenously. And lo and behold, we see a very rapid onset of effect within a week, with maximum effect seemingly occurring somewhere around 8 to 12 weeks, and then sustained over time. The placebo arm rolls over into an open label extension, and they too had this very rapid improvement that then parallels those who originally were treated with active drug. We have now accumulated several years of experience in using this, not only in clinical trial, but also in community use, and have confirmed that we do see this kind of a response: rapid, robust, and sustained. There is another complement inhibitor. It's administered by subcutaneous injection on a daily basis. This is the phase 2 data, which demonstrates a very similar response to what I just showed you. The time course is different, so what appears to be slower is not actually. And again, a very rapid response with daily subcutaneous administration of a target against the C5 component of the complement system. Other companies are developing subcutaneous forms of this as well, and there's talk of an oral form. So the future looks very bright for complement inhibition. What we realized from the original study that not everybody improved. Some 30+% of patients did not meet our primary endpoint at the end of 26 weeks, and we identified a subset of patients that are late responders that did not follow the typical curve, but very slowly over the course of many weeks did so and ultimately achieved a similar response as our original group. We have not been able to identify what the predictor is for this. And so the original thoughts that you only had to treat for around 8 weeks, 12 weeks, and if they didn't improve, then stop, because it wasn't going to be efficacious, now has to be rethought, and we may have to go out some 40 weeks before we can make that decision because of this long, slow improvement that I show you here. What is also interesting with complement inhibition, and the most common side effect that we saw was some headache, very mild, some nasopharyngitis. So a very well-tolerated drug targeting this molecule was that over the course of from the first 26 weeks through 130 weeks, more and more patients achieved improvement. And in fact, some 85 to 90% of patients who were originally on the drug. Here's only 61% improved at the end of the blinded phase and 85% over the subsequent, how many weeks it is, 130 weeks. And here's the placebo, and in MG, placebo patients get better, but when rolled over, they too had this meaningful response over time, which is very gratifying. Now, recognize that this patient population in this study had failed everything. These were called refractory patients, failing at least 2 drugs over the year, or 1 drug plus requiring plasma exchange or IVIG to gain entry, and they still improved. More impressive is the fact this concept of what we call minimal manifestations, which in the examiner, there is no functional weakness whatsoever. In the treated arm, we achieved that in 25% originally, but 70% over the course of 30 weeks. And similarly, nearly 60% here in those who originally got placebo. So half at least were achieving essentially no manifestations of myasthenia gravis with this drug added to their baseline therapy, for which they had failed to achieve any significant improvement. When we look at the rates of exacerbation, and forget the middle one because that's the placebo arm, but this is what's happened in the year prior to the start of study. And we're looking at patient years and epidemiological expression, but there are 105 patient year experiences. And then with treatment with complement inhibition, nearly 75% reduction in disease exacerbation during this open label phase. And when we look at hospitalization rates, an 83% reduction in hospitalization rates from the year prior to study entry through the open label phase. Clearly an impact on part of this burden of disease that I talked to you about earlier. Very impressive. We've designed a new outcome measure called minimal symptom expression, MSE for short, and it's those individuals who achieve an MG-ADL score of 0 or 1. And this is the placebo arm of the phase 2 subcutaneous complement inhibitor, about 12% doing it. And here it is after full dose, and we're achieving about 35%. So we're taking people who are clearly symptomatic, excuse me, and putting them into a state where they essentially have no disease whatsoever. But complement inhibition is not the only reason why we develop myasthenia. We were all, since the 70s, recognized that there was an antibody that bound to the receptor, and this antibody does 2 things. Binding of the antibody, because of the IgG molecule is so large, it inhibits the ability of transmitter to bind to the receptor complex. In addition, as antibodies bind, they cross-link these receptors, which then accelerates a normal turnover process. On average, receptors turn over every 7 to 10 days. They're internalized, degraded, new receptors come back to the surface in a replenished state. And the binding of antibody to the receptor accelerates this degradation process, so we have a net loss of receptors. Complement inhibition in targeting the complement receptor does not alter these 2 processes. You've already heard about the receptor antibodies, and this is just shown graphically. The overwhelming majority are those to AChR. We have this smaller subset of about 5% of patients who are to the MuSK protein, and then a smaller group to LRP4, and then a group that we've yet to identify what their antibody is. It's there, we just haven't found it yet. And why is it important? It's important because our therapies will be different based on what these antibodies are. For instance, MuSK, the vast majority do not respond to cholinesterase inhibitors. They do not respond to thymectomy, and they will not respond to complement inhibition. Whereas LRP4 and others may respond to cholinesterase inhibitors, may or may not respond to thymectomy, and those things have to be determined. And so we have all of these proteins at the neuromuscular junction that can be targets for attack in myasthenia gravis. We know that DOX7, for instance, produces a congenital myasthenia gravis-like syndrome that responds very well to ephedrine and ephedrine-like properties, albuterol and salmeterol, etc. And you've already heard about the mechanisms of what these proteins do at the neuromuscular junction, and I'm not going to go into it. But it's led us to think about what other therapeutic strategies can we use? Can we target these antibodies and stop interfering with this receptor dysfunction? As I said, because the complement inhibition only takes out the destruction, doesn't take out the binding, etc. Well, we have plasma exchange and we have IVIG. And we know that if we plasma exchange folks or give them IVIG, they do get better. There's data to suggest that plasma exchange, by removing circulating antibody or pathological IgG, will improve and does so better than IVIG, in which we administer immunoglobulin and then downregulate the production of pathogenic autoantibody. And immunoabsorption sits in between, and I'm not sure if any of you folks use that as a therapeutic strategy. It's not commonly used in the States. In Russia, it's used quite commonly, but clearly patients get better. And so can we target and remove immunoglobulin and improve function? Well, we have rituximab, but we've already said it's great in MuSK. I'm not so convinced it's that great in AChR positive MG. So what other strategies can we have? Well, what's interesting is that there is a neonatal receptor, originally called neonatal. It's not neonatal, it's ubiquitous. Fc receptor, FcRn. And its role is to recycle IgG and also recycles albumin from degradation. And so IgG antibody and albumin are taken up by the endosome and then bound to FcRn and recycled back into circulation. And that's why IgG has a much longer half-life than other immunoglobulin molecules, almost 4 times the half-life of IgA, IgD, IgE, for instance. And so it became then a rational target for a therapeutic drug. And I'm not going to go into the history of how this was all developed. We don't have the time, but to say that if we target FcRn and block its ability, we can prevent it from being taken back to the recycling pathway through the endosome, but we can shun it to the lysosome for destruction. And so much less of the IgG molecule is taken back into the vascular space. And that's the thrust of a new focus of drugs that will target the FcRn molecule. And here is a phase 2 data that shows that a particular drug called efgartigimod will clear IgG levels. That's shown here in yellow. Here's placebo in blue. And then the green is a healthy volunteer study, not a group in myasthenics. And this is 4 weekly administrations producing this prolonged effect. And this side on the right shows that we can clear IG1, IgG2, IgG3, and IgG4. Remember that AChR positive myasthenia is predominantly IgG3. IgG4 is what we find in MuSK myasthenia gravis. Here's the study design for weekly administrations. Here to 167 patients with generalized disease, 20% of this population were AChR antibody negative. So 80% had AChR positive. And we looked at an MG-ADL score. And so these are the kinds of scenarios. We administer the drug weekly 4 times. Some patients go the whole time. And then some people had a relapse over time, so they get retreated. And the most these patients could receive were 3 infusions in the course of the study. And what do we see? Nearly 70% of patients improve using the MG-ADL, and we defined a responder as those who had more than 2 points, sustained it for 4 weeks. It had to start within the first week following their last infusion. And so here are the differences between placebo arm and treated arm. Here's the same for another metric called the QMG score. 85% of these patients who did respond did so within the first 2 weeks. So much like complement inhibition, like eculizumab, for instance, the effects were rapid, very quick, unlike everything else that we're using. And this slide, and forget the left side, but let's look at the right side. When we talk about this minimal symptom expression, much like complement inhibition, 40% are achieving this versus 11% in the placebo arm. How durable is it? Well, if we look at 4 weekly infusions, more than a third go longer than 12 weeks. And of this group of 15, 7 went the full 26 weeks and never had to be retreated. 22% had somewhere between 4 and 12 weeks. A third had 6 weeks to 8 weeks. These are durations that are much longer than the current responses we see to plasma exchange or IVIG. We can't compare to complement because that's continuously administered. This is pulsed therapy, if you will. And so when we look at those who respond, and I've shown you this already in the first group, here's the second cycle, very similar, so it's repeatable. And I predict that this class of drugs, FcRn inhibitors, will supplant IVIG and will supplant plasma exchange. There are many groups who are involved in this, many companies, and it's a very new, there is one that it will go to for regulatory approval this year, and that's this one here, efgartigimod. All the others are in phase 2, phase 3 trials. So we clear not only IgG, we clear antibody. And when we looked at the AChR negative population to the AChR positive population, very similar responses were seen. And this particular product does not alter albumin levels. Safety, much like what we saw with eculizumab, some headache, some nasopharyngitis, very similar, and some other minor ones, but no significant side effects, no injection site problems whatsoever. And so in closing, I think you've now seen 2 classes of drug that give you targeted immune suppression. Why do we need it? Because our side effect profiles are much better, because the effects of activity are very rapid. Does this rapidity say we can use them in crisis or pending crisis? We need to see that. We now have a target, we have a drug, eculizumab, that can target the refractory population that have failed other things and has been shown to be beneficial. What we need information on is safety in childbearing patients. There is some PNH data with eculizumab to say that it's safe in pregnancy. We still need further data to confirm that. We now see that we can use different formulations. I've shown you some evidence. I share that data sometime in the future. I will tell you from my own personal experience, the children respond just as well as the adults do. So I see that my time is up, and I'll stop here and thank you all, and we can take this to questions.